we're already going to get to in 3 or 4 years. And we all know that in 2019, our economy is already in the dumps, and we were growing on average at a national level at less than 1%. So the risk is real for the National Health Service. And given that cost of employment makes up probably like 60 to 70% of provincial health budgets, the needs to expand healthcare coverage are going to collide with the available money. And when we add to that the rising cost of medical care in general, you know, there were some papers that came out of the Development Bank last year on the medical device inflation and how expensive that is. We look at the health for the privilege will probably feature higher on the list of priorities after the pandemic. So we'll see that medical aid expenses will go up. So somehow as health professionals and health managers in particular, we have to start looking at how we use available resources. And I think the project that Marie presented yesterday provides a window into how, by better understanding what it is that we do, we can better resource the service without this constant threat of demise. And one of the opportunities to do that is to start thinking about things like flexible contracting. Now, I don't really understand all the HR numbers that well. I think that Karen can help us a little bit with that. But there's lots of conversations around what constitutes cost of employment and why it's so difficult to expand that workforce. You know, so we're looking at probably like 60% of salaries to cash components, 40% being allowance, and then there's the thing that you can't budget and and all of that contributes to crowding out any available new capacity coming into the system. We haven't got a recent number, but in 2010, only 3 of newly qualified doctors were absorbed. In 3 out of 10, so 30% of all newly qualified doctors were absorbed into the public service. And that was a function of money and availability to do it. Now we're sitting with a challenge like we've got this expanding health needs that COVID has highlighted. We probably have to do a lot of catch up on key health programs like HIVs, testing and screening, and initiation into care, TB testing and screening, initiation into care. We need to do something about the response to diabetes. And then we have a whole lot of existing unmet needs. So the discussion today is really just think about flexible contract. Because when I presented to the Eastern Department of Health in December of 2010, there's a mechanism of bringing in post-community service doctors to respond to the COVID shock at the time or spike. Amongst practitioners, there wasn't really strong support for taking up a short-term contract, be it a year or whatever. And the preference was full-time employment, which I understand is preferred. But I think what we want to know today is really just try and understand, if we were to do this, what do we need to do? And flexible contracting has many different levels, from managing employee wellness by allowing for different ways of work, by bringing in additional capacity on shorter-term contracts. But there's still some latent capacity needed in order to make that useful. But I do think it's a crisis, and I do think that we need to start thinking more proactively how we manage this crisis that we are in. So, I don't know if you want to say something. I was hoping we can have a discussion and then engage. Is Karen online?
Yes, I'm right here.
So Karen, maybe you can give us, I know it's been some time since you've been out of the HR in South Africa, but your sense on cost of employment, what do you think are some of the issues that we up to?
Okay, thank you. Morning, everybody. If you when you talk about contracting, short-term contracts, are you talking about the utilization of 3/8, 5/8, and 6/8 posts?
Could be. You know,
okay.
One of the options we were thinking was more like a 1-year contract, rather than a period of employment or a 3-year contract. Like the scenario for me is like, instead of we are able to we have a statutory obligation to employ community service staff, right? Positive away post community of service because we don't have a post, right? But we could potentially do a short-term contract, retain that capacity for an additional year or two.
Yes, the department,
yeah,
you're quite right.
So when you look at the department, for instance, will now not expand posts, right? Because they want to lower the official cost of employment. Now, I don't think we can do it through goods and services because that will have an impact somewhere else. But we can still use the personnel budget in a different way by just changing the conditions of service. Over.
Okay, firstly, whenever the department needs money, they don't take it out of goods and services, they take it out of HR. That's the budget that is easily pickable. So it's a very, very, very vulnerable budget because as soon as there's a medico-legal claim, that's where they take the money out of. So, and I also know that they don't really like contract. You take the job or you don't. That's how they feel about it. But you can, of course, then resign. Also bear in mind that one post can only be split two ways. You can either split it into 2 3/8 posts or 1 3/8 and 1 5/8 posts, as long as it equals 8/8. You know what I'm saying? So if you want to take a whole post and only use it at a 3/8, you're losing out. Because it can only be split into two by way of it equaling 8/8. So I'm not sure. I mean, the community service guys are obviously on a 1-year contract, but what is it you envisage by doing a 1-year contract? Do you mean you'd like to contract at a specific hospital and then move around, or what is it? I'm not sure what you mean by contracting. Can you elaborate a bit more, please?
What I mean by contracting is sort of future forward. So when we look at the decentralization of healthcare services to district health,
yeah,
right, we start moving those budgets to the local level. Right? I think part of what we start needing to do is looking at the establishment, trying to understand whether it's the
oh, I'm losing you. Somebody else is talking. Can you repeat that, please?
So in theory, what we're doing or what's happening in the system is we're starting to work out costings at a district level, right?
Yes.
Into which the money is flowing into districts and where are we over and where are we under?
Yeah.
Is a bigger budget envelope. So based on some of the stuff that a lot of people around the world are doing, the process must not be led by the establishment, but rather by the health need. You know, so when you look at that available budget going forward,
yeah,
right, and you hopefully have some strong health management information systems to kind of give you a sense of where you are, you can reconfigure your service in response to the thing that you need to do or need to tell others. And once you establish that, then you can look at your establishment and see how can you balance that establishment out to respond to these inefficiencies or efficiencies or equity gaps. But the current system doesn't allow for it.
No, it doesn't.
And the extent to which there's capability at the local level, either at the district hospital management level or at the district management level to do that, is kind of the conversation that I think we should start having. Because when you look at some of the analysis that has been done on hospital services in particular, they want to move to DRGs. But in order to do diagnostic related groups, you need a very strong information base. And the initial assessment of that, it says that we're actually very poor at the hospital level with our record keeping. Right? So if our record keeping is not great, then we can't actually make a business case as to why we should keep a post or not. Because often with that post, when we deliver care, we tend to work on what's in front of us. You know, so as the people are alive, we try and treat as many people as we can, and there's no real management of the patient from primary health care up to the district hospital level, for that matter. So I was just saying there's an opportunity to look at the broader budget envelope and try and understand how can we reconfigure services so that we are able to meet those essential healthcare needs more proactively. But it does require a change in thinking. And I do think that something like a flexible contract and thinking about the flexible contract in a different way can allow us to expand services. We could improve surgery by putting a budget available for surgery and bringing in that capacity when needed, rather than having to carry the cost that we can't sustain to keep them there full time. But it requires a reorganization of the service in order to be able to facilitate this kind of contracting. And I think it's possible under the idea around the integrated care practice, or as the district hospital as a hub within a contract with private care. I just think that we lack the systems. But to get there, we need professionals to help us try and understand how do we put together that basic package, or how do we put together that decision-making methodology, so we can advocate and influence the department to start looking at its policy in terms of how it allows for flexible contracting.
I think the problem, Russell, that we're facing is that government departments, it's a bit like comparing the Titanic with a yacht. And if you have a yacht, you can change tack very quickly.
Yes.
But the Titanic, it takes about 10 years to turn around the corner. And
absolutely.
And that's the problem with HR, is that we need a mind shift if we were to use the flexibility you're talking of for meeting present need for this year in the department, and then reconfiguring our staffing for next year in the view of what next year will be, so that we might increase staff this year because we're developing something that needs attention. And we would not only need a mind shift in the department to do that, we need a mind shift in the lives of the professionals, which says that I go somewhere to do a particular task, as opposed to I go there because that's my comfort zone and that's where I like to live. And while there are people who like to move, and in other countries, I think it's becoming more and more common for people to be in the job for life, and even to change their careers several times as they're going along completely. In South Africa, it's still very much eventually you sort of get to where you're going to be. And so a lot of people take government services that eventually they're going to be there. And so they want a contract that is open for them to stay until they decide they want to leave, as opposed to something that they know they've got 12 months to do this, achieve the task, and then move on to another task somewhere else. So that sort of aspect of flexibility, where you can shrink and grow your staffing year by year according to budget availability and programming of your hospital activities, where you've got a special campaign, you want to have 3 extra workers, and then you're going to do this and you're going to lay the ground, and then it's going to be continued by somebody else on a maintenance basis. And you could, I mean, it would be great, but it would need an agile mind, and it would need an agile HR department, which we don't have. I think in experience, most people have taken about 3 or 4 years to actually get from the point of envisaging a post to having somebody working in it in the Department of Health, in my experience.
Yeah. And also, just to bring in another point, you know, we speak of HR, and I certainly agree that it can be a very tedious issue. But the main point is the Department of Public Service and Administration, they lay the rules down, you see. And then HR just has to follow and try and be as creative as possible. But for a change to happen, you'd need to present your case to Rolene, the new HOD, and she would need to start negotiations with the DPSA for some flexibility in the, at least in the medical field for the Department of Health. You know, it's
I mean,
one is tied back at all angles. And just remember another thing in terms of flexibility with the 3/8 and 5/8 and 6/8 split, you don't get any benefits on those, and that's the closest you're gonna come. So if you take a 3/8 post, you don't get the benefits that you would get in terms of gems and pension, etc., that you would get if you were full-time. I can't hear anybody. Oh, yeah.
We're still deciding who's going to speak.
I can see your back.
George. And I just wanted to say,
There we go.
I'm more beautiful than my back, let's say. I think that this issue of first, I think 80% of the budget should stay as it is, and just have a margin of 20% or so that is more flexible. And it seems like in George Hospital it was possible to convert some full-time posts into part-time posts. And initially managed some concerns that they would be able to fill those, but it was very, very easy to do. Even though they didn't get any benefits.
So essentially when I was asked to think about flexible contracting, I asked myself, what is the aim of flexible contracting? And so my idea is that the aim of flexible contracting is a mixture between, as Russell talked about, a changing need for staff, but also flexible contracting is easier to get staff to agree to when they're in a position where changing up money for another, like less money for another need, is something that's actually very present in their lives. So I think that your post-consulate doctor, their need is to earn money, is offering loans to pay back, and need for experience. And so in that way, you'd be less likely to find post-consults wanting to do, like a flexible contract. But from what I understand is that it's often a few years into a doctor's career where other needs start to come up. It could be illness, it could be family responsibilities like childcare, elder care, schooling, and also the other thing is professional development. And so, particularly to rural doctors, it's such a gain when you've actually got a doctor who's managed to agree to live in a rural area. And then at present, there's the very traditional post, medical officer post in a rural hospital where it is 40 hours a week with 80 hours overtime a month, if you're lucky. If you're short-staffed in a rural area, you're often doing extra overtime for free. And essentially, it does leave one without much flexibility in terms of, at times, it could be two health professionals who have a child, and then they need to decide if one can get a flexible contract, then they could stay on, but if not, they'd have to leave. And so I think that if we're looking at really improving rural health, it's easy to keep saying, let's encourage doctors to go to a rural area, but retention is, I think, in this stage where it could be possible that some rural doctors would be willing to work less, and often after a few years, when you're experienced, you're working less you can get the same amount done as you previously could do in a day. And so it depends on the doctor, but I think in terms of looking to improve actual rural healthcare with flexible contracting, I think that's the most likely way to go. I mean, overtime is significantly expensive to pay, and so having a doctor who might be willing to do less hours in the day, they can look after the child and do some of their 40-hour work week at night, can actually be one aspect of flexible contracting. But But the main thing that I found very interesting in the article, that from George Hospital that is comments that our generation of healthcare workers are not all about hard work. There's usually a great wish for a work-life balance, and I think even recognizing that, yeah, we're not the same in this generation as before. So yeah, that's it.
So I just like to say that I'm totally focused. I think that there are merits in both the short-term contract.
Unable to hear.
So my name is Marie saying that I'm a physiotherapist. And I think that there are merits in both the short-term contracting that Russell was talking about, as well as the 3/8 and 5/8 posts that everyone else is talking about. But this does require quite a lot of autonomy, financial autonomy as well as managerial autonomy, and that is those are two things that doesn't occur in the Department of Health. It's going to require a fundamental shift, and also if we don't have the capacity right now for that, the skills, and it also requires a really heavy information system, which
It's non-existent.
at this point in time, and to put that in is going to take many years. So I think I would love contracting to happen. I really think it is a great way to go, but like the dinosaur structure of the Department of Health right now is just not going to make it happen. But I think that in the short term, we should really be looking at mid-level workers for task shifting, and we really can get a lot of bang for the buck. We can make the system a lot more efficient and more effective if you manage your mid-level workers properly.
Thank you, I'm Desmond Kehadule, still Desmond Kehadule from Kansas. I just want to touch three things. The first one is on with what we've mentioned. What will mean to the employees or to the staff? And I think we've touched about it, the autonomous financial autonomy. And if we look at concepts, most of them they are looking for financial autonomy. They need to stabilize themselves from the account, and I don't think they will, it will really disadvantage it will really disadvantage them because of others they have background and they have to pay. I mean, I was just thinking about myself and say what happened when I started working. It would be a really disadvantage for me if I would have been given 2 years or 3 years because I had to hire a bed. I bought mine first month and all those issues. So it is on contractual basis. One is going to struggle. The issue of transport in South Africa, next year or next 3 months where I'll be working, is there public transport that I can use because I might not have a car. So that would be a huge disadvantage for majority of some people. So that category might be excluded. Majority might be excluded of the concept. So we go to the senior medical staff where I would now at this stage want to be flexible because I want to do more things, I'm more stable. I might still have a financial problem, but there are more things that I want to do. So I would be interested in that. I mean, my intention was that at 40 years, I'm not going to be overtime or committed overtime, but I'm still forced to. So, and if we take more senior staff now to say, most of the senior staff they'll be willing to do it, but then who will be left in the system for continuity of care and to mentor those juniors? So that is the disadvantage about the flexible contracting on the senior medical staff. the other part could be what we mean for deep rural hospital. Because once we go there, we have to stay there, and what else can we do? In my area, basically, what we want to do is to be working the hospital. So there will be no need to be flexible. Because where are you going? I can, unless you have a farm or you are from that area, you know, but otherwise the farmers there, you will not find most farmers being the doctors or most people, because in my area it's only farming or teaching or this in other countries. So you don't find to say that I can work 4 hours and then the other 4 hours I go and work somewhere, because the next nearest town from where I am is 250 kilometers. If you go to Northern Cape, where really you be say you are flexible, because if you are stuck in the Northern Cape, you will rather stay there for 6 months and not move, because you move with 300 kilometers the next time. So that would be for more deep rural areas in South Africa, it would be more disadvantageous than the flexible thinking.
Hi, my name is Thisdiscussion. I'm also a physiotherapist, and I'm currently doing my master's on rehabilitation and HR. And so my opinion is just speaks to what Maika has said. It's all good and well that we take people's personal preferences into aspect, but when we look at rehabilitation workforce, and in terms of trying to change and motivate for the change, we need the help, we need the information, we need the data set. And for rehabilitation, so after I've managed to collect data on rehabilitation for 3 provinces, and they were 3 rural provinces. And the reality is that rehabilitation is not distributed equitably. And I think that's something that needs to be taken into consideration when you look at contracting. Because we can't just contract and say, okay, well, let's put someone here, let's put someone there. There's so many other factors that you need to take into place. So for my literature review, I'm doing a spoken review of how other countries in the world are looking at the rehabilitation workforce and kind of like how to decide who goes where. And so the main thing is just that at the moment, there's no standardized way of looking at the rehabilitation workforce. But the counter argument is that you can't necessarily have a standardized point of view, because it really depends on what the rehabilitation need is for that area. And so what they've done is some countries have done forecasting dependent on their rehabilitation need and demand and supply. And the thing is, at the moment, we're just looking at who is there, how much work is being done. We're not looking at the population and what is happening in the population, how many of the population needs rehabilitation. And we're not looking at things like what is going to happen to this population over time. And those are the things we need to have a look at. So what we're looking at is, even though that is the case, we still need a structure, which is some form of framework to have a look at the different attributes and what are we going to look at to determine what the need is. And from there, we can start looking at how are we going to do the supply. And I think that's where, once that's put in place, we will only then be able to see if the contracting, where's the need, where can we supply. But in short term, what all of the literature goes about is mid-level workers. And mid-level workers are so important. They can fill so much of that short-term need. And I think, especially looking at Mike's presentation, Maika, and Kate's presentation, and Tina's going to talk about it, it makes a huge difference in just having that support where therapists can then go on and do the more urgent needs. So yeah, and I think the other problem, sorry, one last thing, is just that looking at this,
DOH it's a hard battle to fight, and I'm just like thinking about how hard it was for us to get permission to collect this data, and how hard it was for us to to access per cell data, because we couldn't get permissions to do the research. So we wanted to have a look at the per cell. But in that time, I just quickly wanted to add that Chai is currently doing a audit of the per cell system for DOH.
Karen, I see your hands up. You have the floor.
Yes. I just wanted to mention that even if you are issued with a contract, it still has to be against a post on the establishment.
Morning.
I'll take my hand down.
Morning. I'm Sandra, working in.
I can't hear.
Can you hear me now?
Oh, that's better.
From Kingdom Durban. I'm listening to this discussion, and I'm thinking, taking from what Desmond said, the background of people is not the same. And so the contracting as an umbrella kind of approach may not work as well as we'd like it to. The second thing is looking at what Tandy was saying. South Africa is a bit different in that we have a national government and also have provinces that have autonomy in terms of their staffing needs. So if taking it from what the observation was that in certain provinces, across the provinces, the distribution of therapies is not equitable. It's not necessarily national. It's because the provinces themselves are not prioritizing that particular responsibility. So that then becomes a bit of a problem in terms of how do you then create this contracting against the post that is already put on hold. That's the other thing. The third thing is, in as much as the generation now does not want to work, want to do less, but or whatever you call it. But you see, when you offering them a post, you want a full-time post. They don't want a temporary post. When they are on that full-time post, they want to do as little as they can do. See, there has to be and also taking from what they said, probably one of the reasons why they want to get a permanent post is because they want job security. In the current South African climate, where even as a doctor, you're not sure if tomorrow if you'll be employed or not. Whereas when we started, you didn't even need to open interviews. I mean, you just raise your head, I want to go to Durban, there's a post for you, want to go wherever. But now you have to fight for that particular post. Now the job security issue also comes into play for people who have debts that they still have to pay. So I think there has to be a whole mind shift from national DPSA, not even the Department of Health, the DPSA, and all the way down to the individual provinces. And so maybe we can get it right at that particular stage. But for now, it's interesting.
Hi, my name is teacher and application therapist. As soon as we start talking about human resources, people want to defend their territory and keep what they've got and ideally get more. And this is where we splinter as a rural health movement, as a rehab profession, as a whatever, is that we want to make damn sure that we still have what we want and we get more of what we want. And at some point, if we talk about equity for this country, some of those privileges are going to be lost. Some professions need to grow, and some will not have what they had before. And Desmond, I hear you. People have debts to pay, they want job security, they all that. The reality is we all love that. We would all love a decent salary that allows us to pay off our student loans and support our families. We would all love to know that our medical aid will be paid and so on. The reality is that on our existing budget, our health service does not cover a fraction of the unmet need. When we're talking about rehab, yes, that is my particular field. But the reality is that a lot of the work that is done by doctors in hospitals, working so hard and giving so much, does not translate into lived health and a better life for communities.
That's a big swing.
No, it is. I'm going to say it straight. With the narrowing fiscal space, we have to do a shed load more to make a real difference, to actually make sure that the work that is done in saving lives is actually going to translate into better lives and less poverty. And for that, you need to shrink your curative services. I'm sorry, you do. And you need to put those investments elsewhere, which means that privilege will have to be given up. And that is the reality. And I think we all need to think very, very carefully about, and I spoke on the first day about how we go forward as, you know, as a rural health movement. Everyone's got their task to do, but we have to focus on a shared thing. And as soon as it comes to posts, this is where we splinter and we start fighting each other. And I think this is, you know, this in terms of the angle each person, each organization takes, that's a personal choice. But bear in mind that when we are defending our own rights in our own territory, it can mean sacrificing equity.
My name is Undina. I am a therapist. And I want to ask a question about service packages attached to flexible contracting. The background of that is if we contract a therapist, we need to have a budget for certain assistive devices and tools to work with. I guess with doctors, there is a similar service package of maybe medical tools, medicine supply, and so on, which should be attached to those district or sub-district posts. So how is this included in this idea of flexible contracting?
The point of the conversation was really not saying that the system that we have at the moment is the system that's going to deliver the kind of care that we want. Right? And I think when we do look at the health system metrics, I think many of us have to sort of take a step back and think, should we be thinking about method of care rather than professional involvement? Right? So when we look at primary health care, in particular up to first referral hospital, which is in rural areas, the rural district hospital. You know, in four of the big four health issues that we are dealing with, some would say also social issues, like HIV and AIDS, tuberculosis, maternal and child health, and a growing burden of non-communicable diseases. And we start looking at our coverage, right? The kind of, which is essentially an outcome indicator for all of us as health professionals, be it policy people or practitioners. We're doing a terrible job, right? With HIV, despite all the money that we pumped into it over the last 10 years, it's like 29 billion just for HIV, then there's still costs within the primary healthcare services that can also be attributed to HIV. We haven't even met the first target of 90% of people living with HIV being on treatment. We spend billions on drugs, but we're only halfway there. We only have 4 million people on treatment versus a population of 8 million. With maternal and child health, we haven't even met most under 5,000 kids. We still have children dying of malnutrition in this country. And those are just the disease aspects. If you look at all the other things in terms of quality of living or ability or patient level outcomes, I think it will be an even more shocking situation, the extent to which we really enable people once they leave our health system. And this is not an indictment on the profession. I think it's an indictment on the system and how we manage it. And I think part of this conversation is to say, yes, flexible contracting may be an opportunity in the short term, and we need to start looking at how do we use this crisis, like you said yesterday, it's a wasted crisis, to start thinking about how do we reorganize the system. So instead of saying, look, we need so many doctors at a hospital, can we look at what do we need to resource a health response in a hospital catchment area? And how can we use the skills that's in the hospital to also support primary health? How can we use mid-level workers to help us with up referral and down referral? Right? And how do we think about their patients' complete care journey? so that we can start meeting the health outcomes that we want. We do have a legislative framework to allow us to start thinking about this. Right? So I think a lot of the work is already being done, but there are signs of struggle. So when we look at contracting units of primary care, which are intended, which I think in rural areas will work very well because there isn't that many private actors. You know, we concentrate the management, we use the management capacity that you have in the district hospital to support the entire care network and work out on the progressive targets of saying, how do we achieve effective coverage in our key health system drivers? And then start thinking about how do we resource and contract. So the system doesn't help us at the moment. But as health advocates, I think our job, or at least my job at the Rural Health Advocacy Project, is start having conversations with all of you in how do we get to change the policies so that they can be more accommodating, can allow for more autonomy as envisaged under that tough structure. But to do that, we need to have a shared vision. And I think that shared vision is about improving our care networks. You know, just at a hospital level, 8 out of 9 provinces spend more time in OPD than what they do in hospital wards. Right? And a lot of people don't want to down refer, other people say primary health is poor, and it's been like that for years. But the cost is 3 times higher than what it would be if we were able to offer that service of primary care. And I know many people work in the public sector because they don't want to think about costs, they don't want to say no. But if we're in an environment where we can no longer justify the investments that we are making, then we will become under pressure in terms of the type of services we want to deliver. So I think we're at a crossroads moment now. Everybody has different incentives and needs to look at how we resource and deliver health. But I think we have an opportunity now to use our imaginations and say, what is the change that we want? And then how do we then build an advocacy campaign, change that policy so that we can allow for the kind of things to be done that need to be done. Sorry, Jake.
Hello. So, just something which is a personal idea that could be just a dream, but I have to say, I think that when we look at working smarter, I have to say, I honestly think that the medical profession, like the doctor profession, should be looking at changing our ideas that working at night should always be on top of working in the day. The WHO and the International Labour Organization have recognized that the research shows working longer than 55 hours per week, which is normal for a medical officer, increases your risk of cerebrovascular events by 35% and ischemic heart disease by 17%. And this is usually only seen at the ages between 60 and 69. And so essentially, I'd like to say that, you know, for nurses working night shift is part of the job and it's normal. And I think reducing the amount of paid overtime, because you're paying doctors extra to work overtime because not part of their working hours, could actually be a way to have more staff, which sounds, but not increasing the costs necessarily, because you're looking at less doctors doing overtime. And you know, coming from Tempo that, you know, doctors want the full-time post and then they want to work full-time. I mean, the amount of burnout that happens, I mean, if you don't, the real benefit of flexible contracting is, when it's aimed at the right population, is you're looking at a population you're looking at a workforce that are engaged. When they're able to be hydrated, slept, all of those kind of needs, they're able to engage and produce exponentially a better service delivery, and that's HR, that's proved with many HR studies outside the medical profession that, yeah, you need to get your staff engaged. So for doctors, that's just my thought. And in terms of regulating it, the government does put regulations in place to protect us from ourselves. Many doctors actually really enjoy the extra money, but is evidence to show it's so harmful, I think we should be regulated to protect ourselves.
This time, but I'm very interested in any volunteers who would like to help me turn this into an RHC goal and a campaign, and then we can see how we build it from there. But we only have 2 or 3 minutes. I wanted Victor to have some closing thoughts, but maybe if you can come.
Hello, my name is Tina and I'm an OT. Just speaking from the rehab side of things, and maybe I'll be stepping on some toes. I have been in departments where I've seen therapists seeing very few patients, and I think contracting allows us the opportunity to improve quality of services for our patients, because whether a therapist at the moment or doctor, whoever, whether they see 1 patient or 30 patients in a day, they still get the same salary at the end of the day. So I think if we're fighting for the rights of people in healthcare, contracting could be a good way forward.
Yeah, I think it's obviously a very hot topic. Lots of people are very interested in this issue, and I do think it needs to be explored more. The days when you just think planted there for 40 years are probably gone, and maybe that's good. Maybe you don't have to work 120 hours a week for 40 years and then get your stroke at age 66. So that would be good too. I think we do need to help people to focus on delivering the service in a compassionate way to both the worker and the people who are delivering the service to. So flexibility at local management level is very good, but we do need to, and the systems do exist within public service. I mean, you can have contracts. A lot of our foreign doctors are employed on contracts for a limited period. They don't want to be on a contract, but the maximum they can get is 3 years. And they have to leave whether they like it or not. So, you know, you can use contracts to work for more flexible, but when it takes about a year from advertising a post to getting a person into a post, it limits the ability of management to actually make use of that. And so we need much more local responsive HR, but actually working within the existing regulations. If you have a good HR, it can be done, as long as you don't have a blocking administration which says every decision must be passed to the top. For the management of 55 or 70,000 people, it goes through one person's desk. Then obviously there's going to be delay. There's no superhuman who can sign off 75,000 people's jobs every year. So you're going to take time. So the bottlenecks are deliberately created by our own management system. But the regulations are not actually demand that at all. And we just need to go back to the regulations, put management where management should be, which is at the facility level, give them parameters within which they must budget. And if they step outside of those parameters, they should get wrapped on the numbers. But if they're within the parameters, they should be allowed freedom. And we would have a much more responsive system. Equity should be based on the issue of population, not on what service has been done in the past, because places that had service will continue to have service, and places that don't have service will continue to not have service. So equity is divided on the population you're serving, because you ought to be doing the same thing, so with acknowledgement of some special need areas and special areas. And I think that would help us a lot if we go in that way. And I do think we need to task group to look at some of these things as how we as rural networking can put pressure to facilitate this for government. I don't think the government wants it not to work.
So can you like summarize that? Jane, do you have some closing remarks? And then we can take the discussion offline. Yeah.
The choice to try and summarize is like agreeing to do minutes for a meeting, you get to say what goes in. I think we've all agreed that we need the data to inform whatever we advocate for. And I would put forward that this needs to be on a service basis, not a profession specific basis. we need to look at what is going to serve equity, what is going to serve rural health. We can be fairly sure the professional associations will fight their own, like, you know, I think as an advocacy thing, we need to put first what is going to serve rural populations. So if we can look at what data do we need, like Tony spoke about, what data do we need to identify the solutions that will work best in rural areas, where are the gaps, and build a campaign on that. I mean, we've spoken for years and years about the importance of rural retention and all of those things, but I think we need a focused advocacy campaign at this point in the health system. To me, that's where we need to go. Yes.
And the response package based on the service needs.
Based probably on the primary healthcare package, that's agreed. And yeah, both of them.
Any other remarks? So, like, I think Kate has done a great job, and I think part of that, in summarizing, firstly, I want to thank all of you for taking the time for the early morning discussion. I certainly will try and reach out for deeper discussion around this, possibly a little webinar, try and get in some experts from other aspects of the health system to start talking about it. Right? I don't know whether it will solve the short-term problem of fiscal crisis that we're experiencing. So I think that there's a parallel conversation around service package at the district level and below that needs some ventilation as well, and what kind of product setting we need to do. You know, because I do think that the next 2 to 3 years will be a challenge, but what the extent of the challenge will be how we as a unit or as a movement respond to it. So hopefully we will look at convening a couple of these webinars over the next couple of weeks and months, and invite all of you to bring different aspects to that conversation. But the important thing for me is that we must have some firm agenda around what we want to advocate for, and how we can use our partnerships in the rural health network to strengthen the core for the kind of change that we want to see. So thank you very much for your time and for your commitment, and I wish you all a safe journey back to your respective homes, and that we, you know, that we don't have the fourth wave that is warning everywhere. Yeah, you never know. But thank you very much for your time and for your insights, and look forward to engaging with all of you as that as we talk about these kinds of aspects of prioritization, to get a better idea of how we need to approach priority segment. Thank you, over.